Thanks very much, John. It's a pleasure to be back at the Simons Foundation visiting good colleagues and friends and updating you on what we're doing at Geisinger in Pennsylvania and New Jersey. So we used to have our clinical care delivery system just in the central and northeastern parts of Pennsylvania. We, in the last couple of years, acquired a healthcare system in southern New Jersey, based in Atlantic City, New Jersey. So we now provide care in Pennsylvania and New Jersey, and our insurance operation operates in 5 states in the region. This is a summary slide of the locations throughout central northeastern Pennsylvania and southern New Jersey, showing our biobank, which we brand locally as MyCode, is now over 160,000 patients consented to biobank with the intention to do DNA sequencing. Over 90,000 of those Geisinger patient participants have had exome sequencing through our collaboration with Regeneron Pharmaceutical Company and the Regeneron Genetics Center. And about 3.5% of currently healthy adults get back a clinical report of a disease-causing mutation that puts them at increased risk for early cancer or early cardiovascular events, heart attack or stroke. So I'll talk a little bit about those examples before I move into also looking for genomic variants related to brain development and so-called developmental brain disorders, including autism spectrum disorder. First, one of the reasons I moved to Geisinger, it's sort of an ideal healthcare laboratory. We talk a lot about the concept of a learning healthcare system. Those of you who are not familiar, the Institute of Medicine, now called the National Academy of Medicine, have published a series of about 12 white papers and volumes on this concept. The simple description is, in the process of delivering care today, we generate a huge amount of data as a byproduct of routine care delivery. And if you're in an advanced electronic health record, advanced health IT environment, and simply capture all of that data that's a byproduct of care on a daily basis, and then you analyze that data, ideally every night, to create new knowledge, improve your ability to take care of patients who come into your clinics, into your hospital the next day. So we're committed to the notion at Geisinger that we have a duty to capture as much of this data as a byproduct of routine care on a daily basis to improve our ability to take care of patients the following day. A corollary of that is that in the last 30, 40 years, there's been, according to bioethicists and the primary bioethical framework around biomedical research, a separation of research and clinical care with firewalls in between them and data generated in a research lab was prohibited from being provided back to patient participants or to their healthcare providers. Our bioethics team, our IRB, and our investigators are part of a recent movement in the United States to challenge and reframe the bioethical framework, because scientists, researchers, physicians and other care providers and healthcare organizations like us all and our patients have a shared mission to increase our knowledge, to improve quality of care, improve patient outcomes, keep patients healthier. So if we have that shared mission, we ought to be able to develop a construct to reintegrate clinical care and research in a partnership. So we try to take advantage in every way that we can, sort of the routine clinical infrastructure, all of the data generated as a byproduct of clinical care. And so for that reason, I view the electronic medical record and the clinical data warehouse that includes a copy of Epic as our electronic medical record vendor, but many other clinical databases in the cardiac cath lab, in the endocrine diabetes lab, in the weight management bariatric surgery clinics are all aggregated, as I said, on a routine basis to create this phenotype database. And as a researcher, I view that as free phenotypic data. And our goal is not to duplicate the generation of phenotype data in a research clinic, but to harvest all of that free phenotypic data as a byproduct. And just to jump ahead a little bit with autism. So for example, in our autism clinic, we've adopted the Simons VIP phenotype battery and forced all of our clinicians to use that as the clinical assessment tools that they use on a daily basis. So we're generating free research quality data standardized to national research projects like the VIP project. I was recruited to Geisinger 7 years ago by then CEO Glenn Steele, who had previously been Dean of the Medical School at University of Chicago, who's very familiar with genetics research, a physician, scientist, and investigator himself, familiar with genetics and familiar with the model of Iceland, where Decode Genetics some 20 years ago set up a biobank and got access to the national health system of Iceland. Iceland has very high quality healthcare. They have a single national health database, and Kari Stephenson, the CEO of Decode, got permission to access that national health database and then to recruit Icelandic citizens to volunteer for a biobank to generate genetics data to leverage the longitudinal EHR clinical data of the national health system for genetics discovery, an incredibly powerful and successful model. So Glenn Steele, when he first went to Geisinger, I was at Emory at the time, called me up and said, "You need to come visit Geisinger. It's a really interesting place." And said, "This is as close to Iceland as you can find in the United States." And what he meant by that were several things. One, it's a fairly homogeneous population, so we don't have diversity in small town, rural, central Pennsylvania. But for initial genetic discovery, a homogeneous population is an advantage, and then any findings you make about disease genes need to be replicated in other more diverse populations. Most importantly, people don't move in or out of central Pennsylvania very often. They live there their entire lifespan. If they go off to college, they come back after college. So to have 3-generation family structures, grandparents, parents, and children, is the norm. So for genetics research, to have 3-generation families is the ideal setting. Since Geisinger's been the primary healthcare provider in that region for now over 100 years, there's a very strong and trusting relationship between our patients who volunteer for research, have a great sense of altruism to contribute to knowledge about healthcare to help other families and future generations by participating in research. It's an integrated system, as I alluded to earlier. That means we have 12 hospitals, we have 50 primary care clinics, we have 1,500 employed physicians, and we have insurance. So we have comprehensive clinical data on our patients, and we have claims data from the insurance side of the equation. So that's very extensive and comprehensive health information. So I moved to Geisinger 7 years ago with this vision, being a geneticist and medical geneticist by training, watching the cost of DNA sequencing continue to drop. Said this would be the ideal routine healthcare delivery system to learn when and how having the complete DNA sequence, either exome or genome sequence, can help us to prevent disease, keep people healthier, keep them out of the hospital, keep them out of the emergency room. The ideal time to do that is at birth. In the US, we already have a great public health infrastructure for newborn screening. We essentially get a DNA blood spot on every baby born in the United States. We currently use that to test 30 rare genetic conditions that when you are aware of it can intervene. It can be life-saving or greatly improve developmental outcomes and health outcomes in those children. Plenty of DNA to sequence the entire genome from the current dried blood spots that are sitting around in every state in the United States. So in order for this to become routine in newborn screening setting or other encounter with the healthcare system, we need more data on the clinical utility. So when and how is it clinically useful? When does it allow us to select a better treatment or to prevent disease? And what's the cost-benefit ratio? And there's a lot of concern about any new technology, such as DNA sequencing, actually increasing the total cost of healthcare as opposed to decreasing the cost of healthcare. And I was convinced by my multiple visits to Geisinger that it was just an ideal petri dish or laboratory to do this kind of implementation science, that is the outcomes research, health economics research related to having DNA sequence information on every single patient that touches the healthcare system. So coming from a medical genetics background, this was my vision of building a genomic medicine research team that included MD clinical geneticists, so physicians who were trained and specialized in genetic conditions, clinical genetics laboratory experts, and that's my own background, genetic counselors, which are perhaps the most valuable clinical and research members of our team and any genomic medicine or precision medicine team, as well as strong bioethics faculty members and bioinformatics and clinical informatics expertise. I just show this slide to show off that we've been successful in a small town in central Pennsylvania. Danville, Pennsylvania has 5,000 people. We now have more than 25 genetic counselors, one of the largest genetic counseling teams in the world, including Brenda Finucane, a past president of the National Society of Genetic Counselors, and Amy Sturm, a recent recruit who's president-elect of the National Society of Genetic Counselors. We got a lot of experience in looking at electronic health data and genetics data by participating in the NIH-funded eMERGE network. eMERGE stands for Electronic Medical Records and Genomic Information. It's a collaboration of 9 or 10 outstanding institutions, including Mayo Clinic, Northwestern University, Harvard, CHOP in Philadelphia, Baylor in Houston, and University of Washington and Group Health in Seattle. This gave our research informatics team a lot of experience with exchanging EHR and other clinical data using standard data models between organizations, aggregating into central databases, and then comparing either genome-wide SNP data and now exome sequence data against the electronic health information of larger numbers of patients. So in many genetic studies, any one institution can't recruit enough patients locally. That's particularly true with rare genetic diseases where you need large consortia willing to share data across institutions. We also participate in an NIH-funded project called ClinGen for the Clinical Genome Resource. Krista Martin and I, when we were at Emory, initiated the predecessor to ClinGen. That was a data sharing project involving clinical cytogenetics labs sending microarray data to NIH dbGaP originally, and that evolved into the ClinVar database, intended to be a universal, publicly available database for all genomic variants and using expert curation to determine which genomic variants were disease-causing or pathogenic, which genomic variants were benign and occurred in the normal population with no health or other physical consequence, and trying to reduce the biggest problem we have in genetics today, and that's a large number of genomic variants where we don't have sufficient data or functional evidence to know whether or not they have any clinical impact or functional impact, so-called variants of uncertain clinical significance. So this project now is a very large project. Many institutions that we participate in to gather both structural data, copy number variation data, and DNA sequence data from both clinical and research labs, along with phenotypic data of disease state or healthy individuals, in order to move as many of these variants of uncertain significance into the pathogenic variant bucket or into the benign variant bucket, so that clinicians in the future will be able to look up any genomic variant or change and understand whether or not it has any clinical significance. So at Geisinger, because of some of these ideal aspects of the population and the longitudinal data, decided to launch a biobank project with internal funding in 2007, so now 10 years ago. At that time, I was not yet at Geisinger, but was part of an external scientific advisory board that had recommended that they initiate a biobank. And the first interesting and positive information back from the scientists who were involved in that was that when they went into any clinic, primary care clinic, specialty clinic, adult clinic, pediatric clinic, the consent rate, the willingness to sign a consent to allow access to their EHR clinical data and to allow access to DNA sequence from a blood sample was 90% or higher, pretty remarkably high consent rate to research of any type, and particularly for genetics-related research. So this relates back to my comments earlier about a long, trusting relationship between Geisinger and our patient participants and the communities that we serve. We have a goal, I'll talk more about 250,000 patients recruited into our biobank and DNA sequencing. At the moment, we're over 160,000. That's about 10% of our so-called active patient population. We have a little over 1.5 million patient encounters per year, unique patient encounters per year. About a third of our patients access their health care, make appointments, fill prescriptions, other things through an online portal we refer to as My Geisinger. We can now send out information about research studies, and they can actually consent to participate in research, including the biobank online. And I alluded to our Atlanta Care Health System in New Jersey, where we launched recruitment for MyCode at the beginning of this year and have over 11,000 participants consented there. Any Geisinger patient is eligible to volunteer for our biobank and for genetic analysis. That includes children as young as at birth. Loudon Tissinger and his parents and Loudon were enrolled in MyCode just after his birth. And Ruth Richards, who enrolled in MyCode in her mid-90s, just recently turned 100 years old. I was hiring all these people, geneticists, genetic counselors, bioinformatics, bioethics, because I know Francis Collins pretty well. I knew that he wanted to mount a very large-scale sequencing study of a longitudinal cohort, so healthcare systems that had longitudinal EHR data. He had written about this in 2004. I went to Geisinger in 2010. And by 2013, I was getting antsy, and NIH wasn't coming out with an RFA and funding for this project. So we entered a collaboration with the Regeneron Genetics Center in Tarrytown, New York, and this got some publicity in the New York Times. This shows George Yankopoulos, one of the co-founders of Regeneron and the chief scientific officer, who is involved in establishing that collaboration with those of us at Geisinger. We initially had announced a collaboration of 100,000 Geisinger patients to be sequenced. They built one of the largest DNA sequencing facilities in the world. I'm told they can now do 5,000 whole exome sequences per week in their facility. So in the first 6 months after we announced the collaboration in January of 2014, we were ahead of schedule recruiting. They were ahead of schedule sequencing. So we changed our target from 100,000 to 250,000. I think we could actually recruit 500,000 Geisinger patients into this study, although we've not formally made that our revised target. So with this partnership with Regeneron, it allowed us to accelerate our recruitment and consenting into MyCode, which until that point had been internally funded and sort of a small budget, small internal project, to the now over 160,000 consented, 92,000 sequenced, and 92,000 genotyped. Some of the characteristics, we adopted EPIC, the electronic medical record, in 1996. We were EPIC's second or third customer, so for some of our patients, we now have over 20 years retrospective electronic health information, on average 12 years for those that are consented into our biobank. This is almost 50 clinical encounters per person, almost 500 lab values per person, and almost 100 vital measurements per person, so pretty extensive. More importantly, some of the features of our consent enrollment process, which are still fairly unique. First, a full opt-in consent. Vanderbilt some years ago experimented with an opt-out consent, meaning you're automatically in the biobank unless you specifically and proactively say you don't want to be in. I thought that was incredibly clever. I recommended it to Geisinger, fortunately, when I was on the SAB. Fortunately, they didn't listen to me because the NIH came back later and said that's not adequate consent. Everybody needs to proactively consent and not through an opt-out mechanism. We have a broad ability to recontact. That means our patients who consent say, feel free to contact me if you need additional information about me, my family members, my health record, or you want to offer for me to participate in additional research studies. We've talked about the longitudinal EHR data. Longitudinal samples, I didn't mention earlier, when we consent people, most of the time we don't ask them for a blood sample, blood draw just for research. We simply put an order into their Epic medical record saying they're consented for my code. So next time their doctor orders a clinical blood test, the phlebotomy lab knows that they're consented and takes an extra tube that goes to the genomic score. So it's almost free, and it doesn't add any imposition to the patient. And that means every time they have a clinical blood draw, we get another sample to the genomic score. The most unique part is in 2013, we made a pretty radical change in our protocol and consent, and that is, again, this evolving ethical framework, challenging the old notion that you separate research from clinical care. And as a health system, and all of us involved in the genetics research are clinically trained, have a clinical component to our jobs, and we knew that we were going to get results that would have clinical relevance or impact to the patients. So we started questioning whether it was ethical to collect this data in a research setting and then not tell the patients when we had a clinically relevant result. So we did a lot of patient focus groups to ask our patients what they thought. The huge majority thought, actually interestingly, under the old consent at Geisinger and elsewhere, where it says any data generated in this research project will not be communicated back to you. Virtually every single patient said, yeah, I know I signed that consent saying that you wouldn't give me back research results, but I know, since you're my healthcare system, that if you find something important to my health, I know you're going to tell me anyway. So that's what all patients thought prior to our change. And so now the consent form says, we are going to return anything that we determine, our expert medical team determines is relevant to your health, and that there's actionability. Knowing that information allows the patient and their primary care physician and specialist to do something to reduce their risk of health problems. I was pleased when I was sitting at a genetics meeting for the Precision Medicine Initiative in Bethesda a couple months ago. Sek Katharesan showed this slide on large biobanks around the world and highlighted the UK biobank with the goal of 500,000 people. The VA system, U.S. Veterans Administration in the U.S., has a 1 million veteran program, and then put Geisinger on his table as well with this 500,000 number, which we haven't officially claimed yet. But then talked about the genotyping arrays technology format for the 3 different biobanks, and then the status of current status of sequencing, where the UK Biobank is doing a pilot project with exome sequencing. The Million Veteran Program is doing a pilot project with whole genome sequencing, and Geisinger, in partnership with Regeneron, is the only one of these at the moment committed to sequencing everybody in the biobank. Most importantly was the last line, the discussion around return of results, where the UK Biobank currently is not allowed to return any results back to their participants. The VA Million Veteran Program is not allowed, and we're one of the only major biobank sequencing programs that has the intent to provide clinically relevant results to as many patients as possible. If Kari Stephenson from Decode Genetics were here talking to you today, he would tell you that through their genetic studies, he now knows every single person in Iceland with a BRCA1, BRCA2 mutation at greatly increased risk of early onset breast ovarian cancer, and he can't tell them. So the nature of the consent doesn't allow him to give that potentially beneficial information back. That's the standard in all genetics research. Now that's changing, and for most people, it seems pretty bizarre that that was ever the standard. But it is, and it is still true. Now, we know from recent discussions with the VA and with Kaiser Permanente and some other groups, everybody's rethinking this. Everybody has the intent to move into a return of results, although everybody's being very cautious about how quickly they make that transition. So what do we return? So how do we decide what's clinically useful, what has sufficient evidence base? We were fortunate in 2013 when we made this decision that the American College of Medical Genetics and Genomics, the professional society for the field of medical genetics, was discussing the advent and increased adoption of exome sequencing in a clinical setting. So if a patient comes in with an undiagnosed disease X and you order exome sequencing, and by chance you find a BRCA1 clear pathogenic mutation, do you tell them or not? The committee debated this over quite a long period of time and finally decided that for certain conditions that were clear Mendelian single gene disorders with very high penetrance, meaning the likelihood of getting the disease if you have a pathogenic mutation was very high, and there's something you can do about it to reduce your risk, then the answer is yes. So we simply said, well, that's the clinical guidelines. Why don't we just adopt that in our research setting? Also, fortunately, on this initial committee, Krista Martin and Mark Williams, both faculty members at Geisinger, were part of that expert committee. Krista Martin from Geisinger now chairs that committee. So we were following in a parallel process the evolution and updates to this list of evidence-based gene disease pairs that have significant clinical actionability. I've already said these are well-known, well-studied, single gene monogenic conditions, high penetrance, so high likelihood of getting the disease if you have a pathogenic mutation, medically actionable. That means at the moment, not looking for carrier status for cystic fibrosis or others, not looking at pharmacogenomics, drug metabolism markers, and not looking at associations and slight to moderate increased risk for common diseases. So when you follow that recommendation, how many participants in a biobank genomics project like Geisinger will be found to have a disease-causing mutation? Well, we published 2 papers with our Regeneron collaborators in December of last year, so over the Christmas week these were published. And this was an analysis of the first 50,000 Geisinger patients, volunteers, that we sequenced. These were general healthcare population, so some were healthy, some had routine common adult diseases, diabetes, other things. And in that cohort, we found, I do have this modern pointer here, 3.5% of healthy adults, and this is consistent with other published studies, 3.5% have a conservatively called clear disease-causing mutation in one of the ACMG list was 56 genes, now 59 genes. We used a very slight modification of that. You may see some slides that refer to the Geisinger 76 genes, but not too different from ACMG. And most of those diseases are 2 categories: early cancer, early cardiovascular events, heart attack. And I'll give you some examples of those in a minute. And here are the most prevalent of those conditions. So we'll start with hereditary breast ovarian cancer, the conditions most people are familiar with, caused by mutations in the 2 genes, BRCA1, BRCA2, cause very early onset breast ovarian cancer in females, prostate cancer in males, made famous by Angelina Jolie a few years ago by her decision to be public about her own BRCA status and her decision to have prophylactic surgery to reduce her risk. But increased mammogram, breast MRI, or prophylactic surgery can greatly reduce risk of cancer. The published prevalence for these 2 genes is 1 in 400. I'm not going to go into detail, but our data suggests it's probably twice that common. This is a recurring theme by all population studies, doing DNA sequencing rather than doing clinical ascertainment of Mendelian diseases. These Mendelian diseases are usually twice as prevalent as we think they are because we're missing half of the cases by ordinary clinical guidelines and clinical care. Lynch syndrome, early onset colon cancer due to a mutation in one of 3 different genes. Increased surveillance can reduce risk of cancer, about 1 in 400. And familial hypercholesterolemia, which I didn't know a lot about until we started looking at this data, is high cholesterol due to a mutation in one of 3 genes that affect primarily LDL cholesterol levels. And there's good evidence in the literature that if a person's FH genetic status is known, so the high cholesterol that you get back is due to a genetic condition, your physician is more aggressive in treating your cholesterol, so they start high statin doses earlier than the gradual increase. And patients are more compliant with their medication. So there's evidence from other groups that this improves outcomes and reduces the risk of heart attack and stroke in this population. This chart that was in the second paper in Science shows a distribution of LDL cholesterol along this axis. Blue is everybody who has a mutation in one of the 3 genes that causes familial hypercholesterolemia. Pink is the general population without a mutation in one of those 3 genes. And it shows that a mutation in one of these significantly shifts the average LDL cholesterol to the right, so to a higher LDL cholesterol, higher cardiovascular risk, although there's still significant clinical variability among all individuals who have an FH mutation. This shift of a quantitative trait due to a Mendelian mutation should be familiar to many of you in Simon's in terms of looking at the impact of de novo CNVs and de novo single gene mutations in autism with the same resulting clinical variability, likely attributable to common variation as well as environmental influence. When we look at the, I told you we have almost 500 lab values on many of our MyCode patients. So we look at their LDL cholesterols, and sure enough, they're mainly elevated. So you could make a clinical diagnosis from the lab values in their chart 70% of the time or more. So they have consistent lab values, although in the United States, we make the clinical diagnosis of FH about 10% of the time. So most physicians don't pay attention to family history and to early and increasing LDL cholesterol values. European countries do a much better job than we do. So as I said, we think that knowledge of the genetic mutation will help our physicians to treat more appropriately. Many of the patients, when we look at their EHR, are on statin treatments. Most of them are being undertreated and are not meeting goals for cholesterol levels. So again, we have the opportunity now to see what the impact is on this knowledge for treating physicians and for patients. What I'm most excited about for FH is the American Academy of Pediatrics currently has published guidelines that in an FH family, so once you find a mutation and you analyze all the first-degree relatives, children in those families should be evaluated, so cholesterol screening. If cholesterol's high, genetic testing. And if genetic testing is positive, then treatment, including statin treatment, should be started by age 8. So the early heart attacks given an FH mutation come in your early 40s for males, early 50s for females, but that's after a lifelong exposure to high cholesterol that increases throughout the lifespan. So instead of waiting and being reactive to the high risk range in 30s or 40s, if you want to keep the atherosclerotic deposits that damage the heart and increase the risk of heart attack start in children. So the recommendation is evaluation, testing, and treatment started by age 8. So we now have the opportunity in our health system to identify every family and particularly every child carrying an FH mutation and try to keep their heart healthy from a young age. Those of you who are online could Google Geisinger and my code. At the bottom, there's a URL that talks about return of clinically relevant results. This is a scorecard that says we've done a clinical lab report and offered genetic counseling to over 400 patients who volunteered for this research project and now have BRCA1 or 2, Lynch syndrome, familial hypercholesterolemia, and then a smaller number of some less frequent conditions. Barbara Barnes is one of our patients who's encouraged us to tell her story and use her name in telling the story. She's a 57-year-old Geisinger patient who was found to have a BRCA1 result. When we contacted her and talked to her, turns out she had no personal history of breast ovarian cancer, no close family members, so she would not have qualified for genetic testing for BRCA1 and 2 by ordinary clinical guidelines and recommendations. At 57, she's actually outlived a lot of the risk period that usually starts in the 30s, but she said, you know what? My husband and I are raising our grandchildren. I need to stay healthy for at least 15 years to finish raising our grandchildren, so I want to be super conservative. So I'd like to have prophylactic surgery to remove my ovaries and fallopian tube. So she had a normal breast mammogram, normal breast MRI, had an ultrasound exam prior to prophylactic surgery that didn't show anything, and then at surgery, a golf ball-sized tumor on her right fallopian tube that was removed and chemotherapy started. So likely life-saving intervention for a 57-year-old woman who had no clue that she was at increased risk for this. We now have 4 cases. This shows 3 cases of BRCA1 and 2. The first one is Barbara Barnes. You've just seen a 56-year-old woman with BRCA1 positive, and then breast MRI revealed early pre-symptomatic, so not yet detected, breast cancer in her, and a 55-year-old man with a BRCA2 mutation who had a PSA, elevated PSA testing after this, and then a prostate biopsy that confirmed early-stage prostate cancer in him. So 4 cases of early cancer detection prior to any clinical symptoms on the basis of genetics information. So our short-term, long-term goals are find every patient and family in our health system with FH. We've talked about already the potential benefit, particularly to children, and determine the optimum age and method of treatment with statins or the newer PCSK9 inhibitors. Find every person with BRCA1 and 2 mutation for early monitoring detection of breast ovarian cancer. This could be an interesting cohort of individuals for so-called liquid biopsy, so sequencing peripheral blood, looking for early signs of cancer, genomic mutations, genomic profile that would predict early stage cancer, and obviously to move on to other diseases. So now I'll switch to thinking about what we call developmental brain disorders as a broad category that includes developmental delay, intellectual disability, autism spectrum disorders, and pediatric epilepsy. Genetics has taught us in the last 10 years or so that these different clinical diagnostic categories have often a shared genetic etiology, in the same genes and the same copy number variants can be found in clinical cohorts across these different diagnostic categories. So since we had this exome sequence data on 50,000 individuals initially, and our Regeneron colleagues had pretty good algorithms to identify copy number changes, so deletions and duplications of chromosomal regions known to cause intellectual disability, autism, these developmental brain disorders. And then we had sequence data to look at point mutations. We decided to start looking at this. Now remember, we're looking at our general healthcare biobank. The average age in our biobank is 60 years old. So these are not primarily children, they're largely adults and even older adults. So we didn't know exactly if we started looking for these copy number variant genetic disorders in a broad healthcare adult population what we would find. But we looked at almost 50,000, had good quality data, and we looked at a selected subset of 33 so-called recurrent CNVs known to be associated with brain development, brain disorder. Other studies have referred to these as neuropsychiatric copy number variant disorders. And we found a host of characters, people in the Simons VIP and other genetics people will be familiar with some of these now well-known recurrent microdeletion and microduplication disorders in our adult population. And then we looked in those individuals to see how often did they have documented in their EHR things like intellectual disability, which I have to admit is one of the most poorly documented things in an electronic medical record. So finding any documented ICD-9 codes is remarkable. Developmental delay, autism spectrum, ADHD, epilepsy, etc. And you see in the far right the percentage in these different categories of finding known genetic disorders associated with microdeletions, microduplications, was often several percent. Now, the most remarkable number is this bottom number, 0.8, because that's the total. That's the total 50,000 adults who all think they're normal and don't have a diagnosis, for the most part, of many of these conditions. And this is consistent with data from Iceland. Decode has published a similar, almost 1% of the population of Iceland has a known neuropsychiatric copy number variant genetic disorder. And then when you call them in and test them, they have mild to moderate cognitive, behavioral, neurologic, psychiatric findings. So in our population, almost 1% or 0.8% had these well-known, well-described copy number variant disorders, and I'll tell you a little bit more about some of these. I personally would add this 0.8 to the 3.5% we've already talked about, which were known single gene Mendelian disorders from the ACMG 56. So we're at 4.3%, both of those being very conservative estimates. In that group, you find well-known conditions like Prader-Willi syndrome associated with deletion of chromosome 15, a more recently described microdeletion 17q12, as well as others, and I'll highlight a few features of these. Also finding the reciprocal duplication disorders for many of these. If we look at 22q11 deletion syndrome, previously called velocardiofacial syndrome or DeGeorge syndrome, in the first 50,000, we found 15 cases. Of those 15 adults, 3 of them had a clinical diagnosis or ICD-9 code consistent with velocardiofacial syndrome, but 2/3 of them had clinical features, either physical medical features consistent with velocardiofacial DeGeorge syndrome or behavioral psychiatric ICD-9 codes consistent also with these conditions, with this condition. For 16p11.2 deletion, there were 24 adults in our biobank with that. Typical of this condition was the increased frequency of obesity, which tends to increase with age, and since this population is an average age of 60, the BMIs were pretty impressive. So I show the curve here. Now, Geisinger, embarrassingly, the normal BMI or average BMI in our general population is 30. So our average BMI is overweight in central Pennsylvania. But now those with 16p11.2 deletion have an average BMI well over 40, and approaches 90 and above in some individuals with this deletion. So remarkable obesity. And a number of these patients we have a very large bariatric surgery program at Geisinger, so a number of these individuals have had. So one of the phenotypic features or EHR diagnoses or codes in this is 28% have had bariatric surgery. Now, interestingly, they respond pretty well to bariatric surgery. Those of you familiar know that everybody loses weight. Some people regain weight and don't really benefit long term. So far, these patients seem to respond well and keep most of the weight off. So that's useful information to have about them. So we then had a discussion as we started looking at this data. What about returning the information to these adult individuals who volunteered for MyCode, that we found a genetic disorder that is known to be associated with, in some cases, cognitive deficits or problems, learning problems, increased risk of autism, increased risk of adult psychiatric conditions. In order to do that, we thought that we had the clinical expertise and a lot of experience with counseling families with children and interacting and counseling adults with these conditions. We thought there was potentially health benefits, both medical health benefits, behavioral and other treatment benefits to this knowledge. In order to do this, we had to do an orthogonal or secondary CLIA confirmation, because the original data at Regeneron is in a research laboratory setting. We went through our IRB and an external ethics advisory board to discuss this modification in our protocol, because we were moving away from breast ovarian cancer, cardiac disease, the ACMG 56 list, into a whole new area of brain disorders, and got their support for this and developed a process including genetic counseling. So it was kind of interesting. Brenda Finucane, some of you have met and is an expert in dealing with adults and children with these genetic disorders. She initially made the first few phone calls to, again, these are adults in their 40s, 50s, and 60s, and the phone call would go, do you remember that you volunteered for MyCode? Yes. Do you remember in the consent, we said if we find anything relevant to your health that we would tell you? Yes, I do. Well, we think we may have found something relevant to your health. Would you be interested in coming in and hearing about that? Oh, yes, I'd be very interested. And she reported the first few cases. The person didn't report any significant medical problems. Other problems sounded quite reasonable. But then almost every single adult in their 40s, 50s, and 60s has showed up in clinic with one or both of their parents because they live at home. Never married, never had children, unemployed or underemployed, and report lifelong experiences with learning difficulties in school, significant anxiety problems, etc. So a couple of quick cases. One 22q11 deletion 48-year-old man living with his parents, single, never married, graduated high school, works in an assembly manufacturing plant. Typical facial appearance. When he came to clinic, one of our neurodevelopmental pediatrics said, why is that adult with 22q deletion sitting in our pediatrics clinic? So obvious facial appearance. No significant ongoing medical conditions or prior surgery, but typical of 22q. Had a psychotic break in his mid-30s or at 35 that required hospitalization and drug treatment. He was stabilized, and then his psychiatrist started weaning him off his medication, and he had another psychotic break. So as Brenda was counseling this man, and he came to realize that he had an underlying medical condition that was causing some of his learning problems earlier, and then the psychotic episodes, he reached and grabbed her and said, "Can you please call my psychiatrist and tell him to quit taking me off my medications? I do so much better when I'm on my medications." So knowing that this is a chronic condition and it's not going to go away, even though he stabilizes on medication, was very helpful to him. A 16p11 deletion case, 44-year-old woman who had been married but was divorced, no children, living independently. Her lifetime high BMI, 77, although she lost 100 pounds through bariatric surgery. Had early speech delay, did graduate high school with some support, history of depression, anxiety, and being treated with medication. Most of her problems were the obesity-related sequelae. So it's early. We've done this now with about 40 patients with these well-known CNV disorders, all in their 40s, 50s, and 60s. But the anecdotal reports, which we're recording and accumulating, have all been positive on the part of the participants. The stories are typical that they had these lifelong learning issues, lifelong anxiety issues. They were different from other members of their family. Their parents didn't believe them, their teachers didn't believe them, and now they had an explanation for their lived experience and being different from other members of their family. And they're all eager to participate in other follow-on research studies, including additional phenotyping or other, in order to help others with similar conditions. So I've already said this is 0.8%, almost 1% of the population. 40 to 50% of these identified as an adult have one or more ICD-9 codes or other EHR documented clinical findings consistent with the underlying genetic condition, although most of them have not been appropriately diagnosed. I think I have a few minutes to give you a glimpse of another story. This will be presented next week at the American Society of Human Genetics, for those of you who may be attending, by a really talented junior faculty member now, Andres Marina De Luca, who's been working with us since Emory days and Geisinger and is now doing a neuroradiology fellowship at University of Pennsylvania, but will return to Geisinger when he completes that. A number of years ago, he identified a patient at Emory with a homozygous deletion of a single gene that caused cerebral palsy, or CP, in that individual, that caused him to do a great literature review on what was known about the etiology of CP. As you may know, it's relatively common, so 1 in 300 to 1 in 500 are the most common motor disability in children. But there's a widespread misconception still in most textbooks that birth asphyxia is the major cause of CP, despite the fact that all the best recent epidemiology studies have shown that birth asphyxia is probably less than 10% of the cases, and the dramatic increase in the frequency of cesarean sections at birth to avoid birth trauma, birth asphyxia, which has had no impact at all in reducing the frequency of CP. So really, we don't have a very good idea of the etiology of CP. A number of groups around the world now are applying exome sequencing to look for potential genetic etiology. So again, looking at our adult population and exome sequence data on 60,000 Geisinger patients, Andres and his group identified in those 60,000 103 individuals with well-documented CP in their electronic health record, so 1 in 600 in this case. And then of those 103 individuals, clear high impact loss of function mutation, so nonsense frameshift mutation, in 17 cases, or 16.5%. 7 of those were in known genes associated either with CP-related phenotype or other developmental brain disorders. I'll show you a quick summary. 10 cases in potentially novel CP candidate genes. This is the list of genes in red. The first 7 are either known CP, other developmental brain disorders, one mutation in MECP2 associated with Rett syndrome, and it's frequently the case that Rett syndrome are, quote, misdiagnosed early on as having CP. It's probably not a misdiagnosis, but a CP phenotype in individuals with MECP mutations in the context of Rett syndrome. If you extend beyond these clear, complete loss of function mutations and look at missense variants that are predicted to be deleterious by multiple predictive algorithms and not identified in normal population databases, there's another 40 cases. And in all of the loss of function mutations and missense variants I'm showing are not present in the exact database, the 1,000 Genomes Project, et cetera. So if you were to accept these moderate impact missense mutations, it would be over 50% of CP cases have a mutation in a single gene that might be the etiology. So this is early on, but as I said, many groups around the world are doing this kind of exome sequencing, pooling their data together to get a better estimate of the frequency of genetic etiology for CP. Like other developmental brain disorders, CP is not one thing, but many different conditions now with many different genetic etiologies. And I think I'll stop with that brief preview of that story and thank my genetics genomics team at Geisinger, as well as our partners and collaborators at the Regeneron Genetics Center. And maybe we have time for some questions. Thank you very much.